Hello, good evening to all. I'm Giovanni Mosiello. I am the coordinator with Professor Jean-Marie Joannick of the Spina Bifida working group, transcern working group between EUROGEN, ERN and ITHACA ERN, and welcome to all. I would like to introduce Professor Zimak, please.
Вітаю, шановні колеги. Я є медичним генетиком, представником Міжнародного благодійного фонду OMNI-NET Україна і представником Хмельницької міської дитячої лікарні. З більшістю із вас ми вже знайомі, але сподіваюся, що наше коло розширилось. Ми мали з вами чудову нагоду познайомитись минулого року на двох попередніх вступних вебінарах, які стосувалися, власне, серії цих вебінарів, організованих європейською організацією EUROGEN, Міжнародним благодійним фондом OMNI-NET для дітей та Міжнародною федерацією Spina Bifida та гідроцефалія. Прошу пані Розен, яка представляє Міжнародну федерацію Spina Bifida та гідроцефалії.
Thank you so much, and it is a real pleasure to seeing you all here. And as Secretary General of the International Federation for Spina Bifida and Hydrocephalus, I'm sending you the best wishes from Brussels. And these series of webinars offer an exchange of experiences between colleagues in the EU and colleagues in Ukraine on the important topic of multidisciplinary care. And today is, of course, a starting point which allows for broader discussions throughout the year. But we trust that these topic-specific webinars can really inspire your work in support of the families. And for now, wishing you an inspiring meeting. Back to you, Professor Masiello.
To be there, dear colleagues from Ukraine and from Western Europe. And today we will have this webinar that will be held by two dear colleagues, dear friends, Dr. Giacomo Esposito, that is a pediatric neurosurgeon in Rome, Bambino Gesù Children's Hospital, and Dr. Timothée de Saint Denis, that is a pediatric neurosurgeon in Hospital Armand Trousseau in Necker in Paris. And the topic of today will be about etiology, epidemiology, pathophysiology, and neurosurgical management of spina bifida and other spinal dysraphisms. Please, Dr. Zimak.
Дякую, пане Мусієло, за представлення наших сьогоднішніх шановних спікерів. Це колеги пана Мусієло, доктор Giacomo Esposito, як ви вже зрозуміли, дитячий нейрохірург із лікарні Бамбіно Gesù, і дитячий нейрохірург із лікарні Трусо і Некера в Парижі, доктор Тімоті де Сен Дені. Будемо говорити сьогодні в першу чергу про спінальні дисрафізми і про сучасні нейрохірургічні підходи до їх корекції.
Then we will have the presentation, and please note that for this webinar we decided that if you wish to ask a question regarding the presentation, you can do that by typing into the question box that is assigned on the slides. We shall take the question away and answer them at the beginning of the next webinar, and they will also be published on the ERN EUROGEN website. In the next webinar, we will see if we can answer also during the presentation, but for this first webinar, we choose this modality. Thank you. And Dr. Zimak, please.
Так, дякую, пане Мусієло. Невеличкі коментарі щодо організації сьогоднішньої роботи і організації запитань після презентації. Запитання можна поставити безпосередньо в письмовій формі, ввівши його в бокс для запитань. Ми Ці запитання будуть взяті до уваги і будуть детальні відповіді на них надані на початку наступного вебінару. Також відповіді на ці запитання будуть опубліковані на сайті ERN EUROGEN. Ось у такому секції питання та відповіді в PDF-файлі. Їх можна буде отримати і прочитати в будь-який час після закінчення вебінару. І так само обговорення цих питань, ну, як ви розумієте, відбудеться на початку наступного вебінару. У мене є ще невеличке оголошення специфічно для нашої української аудиторії. У разі повітряної тривоги всім потрібно буде спуститися в укриття. Майте, будь ласка, це на увазі, бережіть себе. Пане Мусієло?
Thanks. And I believe that now we can start with the presentation. So I would like to invite our fantastic technical support, Darren, to start with the presentation, and then we will come back with you for the discussion and at the end of the presentation.
Good morning, everyone. I am Giacomo Esposito, and I'm involved in treatment of patients with spinal dysraphism at the Bambino Gesù Hospital in Rome. Today, we are going to analyze the epidemiological data, etiology and pathophysiology of spinal dysraphism. Neural tube defects are a broad spectrum of congenital anomalies due to the interference during the development of the brain and spinal cord in the first weeks of gestational period. They may be classified as open when neural tissue is exposed without a skin covering, or closed when there is a skin covering on the neural. Closed spinal dysraphism, it is a broad range of skin-covered congenital anomalies, are caused by embryological defect in the neural tube formation process. And it is important to differentiate it from by tether cord syndrome. In fact, the tether cord syndrome is a condition in which we have neurological, urological, or gastrointestinal abnormalities due to a stretching on the lower part of the spinal cord, and in particular way when we have a stretching on the conus medullaris and cauda. The global incidence of spinal dysraphism is about 1.3 per 1,000 live births, but it is important to differentiate between opens and the closed forms. The prevalence of spinal dysraphism has been in decline in the world over in the last few decades due to the better nutrition for women, folic acid supplementation, improved antenatal care, and high-resolution ultrasound for prenatal screening. Regarding upper forms, these have declined sharply over the years as prevention strategies. And actually, we have 500 to 1,500 children with mielomeningocele per year in UK and in United States. For the other forms of dysraphism, the data are high variable. Incidental findings are estimated to be present in 25–30% of people, and the prevalence of spinal dysraphism on MRI is 0.24 to 4%. Cadaveric studies show a prevalence of filum terminalis lipomas in 6% of cases. For the spinal dysraphism and other type of lesion, the incidence and the prevalence is variable. For example, simple sacral dimple are recognized in 2–4% of babies, and other type of spinal dysraphism are more rare. The etiology of spinal dysraphism is not completely understood, but it is clear that it is a result of the neural tube defect in the phase of closing, of closure. The folate deficit during a pregnancy is the most known categorical factor, and in fact, for folic acid supplementation determine a decrease of incidence of hyperfolate annus and a reduction of myelomeningocele. And in this slide, we can see the cycle of folic acid, and it is involved in the process to repair and to correct the damage on the DNA and RNA. Spinal dysraphism is a multifactorial pathology, and in fact, many factors are involved in the pathogenesis. In this slide, you can see what type of factors are involved. In fact, we can note maternal nutrition, other maternal factors, and environmental factors. Maternal factors like alcohol and caffeine abuse or low diet quality is high important, and other factors are, for example, smoking or progestational obesity and valproic acid. But in the literature, there is a correlation between some type of syndromes and clinical pattern and spinal dysraphism. For example, in caudal regression syndromes, there is a correlation between this and maternal diabetes. And in case we have myelocystocele, the relation is in case to have abuse of retinoic acid. In the normal spinal cord evolution, we have 200 genes involved in this process, and the genetic basis for occult spinal dysraphism is a very important aspect. For example, in Hispanic, we have a higher prevalence of occult spinal dysraphism, and we have a higher percentage of spinal dysraphism in trisomy 21, chromosomal 22 deletion, and in some conditions has Bacter and Currarino triad. There is the formation of spinal cord is the most important aspect in the evolution and in the evaluation of spinal dysraphism. In fact, embryogenesis in the first 2 months of gestation age in gestation can be divided into 23 stages. Neural plate is formed in stage 8 around the 18th day. Neural tube development occurring in this condition during weeks 2 to 6 of gestation and progress through a complex multi-step process. We have 4 stages, main stages: gastrulation, neural tube closure, that can be divided in primary neurulation and disjunction, and secondary neurulation. Gastrulation is a process in which the embryonic disc becomes trilinear, consisting of endoderm, mesoderm, and ectoderm. During this stage, a neuroenteric canal also forms, and it is a temporary connection between the dorsal and ventral surface. Alteration in this stage may cause split cord malformation and neuroenteric cyst. The phase of neural tube closure is divided in primary neurulation and disjunction. Primary neurulation is the formation of the brain and the spinal cord to the mid-sacral laryngeal. A special collection of mesodermal cells that forms the notochord, which include the differentiation into neuroectoderm. The neuroectoderm begins as a neural plate that invaginates centrally and folds upwards to fuse in the midline. Neural tube formation is a discontinuous process that is initiated at multiple closure sites and then proceed bidirectionally. An alteration in this phase results in a myelomeningocele. At the end of primary neurulation, the neural tube separates from the surface ectoderm in a process known as disjunction. And incomplete disjunctions may be the cause of, for example, of dermal sinus, or in case we have a premature disjunction, we can have a defect as lipomeningocele. Neurulation is the last stage in which we have the formation of spinal cord and is the formation of the caudal part of spinal cord. In this case, we have a process in which we have a regression and differentiation process known as retrogressive differentiation to form the conus medullaris and filum terminalis. So in this case, and in this table, we can see what type of distribution we have in case of spinal dysraphism related to the developmental stage. Cutaneous markers can be useful to suspect spinal dysraphism, and in these articles we can see what type of stigmata we can relate to the risk to have a spinal dysraphism. We have three categories: high, intermediate, and low. And for example, the stigmata highly related to spinal dysraphism we have acrocordon, pseudotail or two-tail, aplasia cutis and congenital scars, dermoid cyst or dermal sinus, or infantile hemangioma, a large infantile hemangioma. In the intermediate risk, we can consider a typical dimple that it is far more 5 millimeters diameter, or far more 2.5 centimeters from an albergue, or a large dimple, a infantile hemangioma less than 2.5 centimeter, or hypertrichosis area. And at the end, the low risk of correlation with spinal dysraphism is present when we have a simple dimple, hyper or hypopigmentation, melanocytic navy, and teratoma. But in the management of the patient with spinal dysraphism, it is very important to know the consequence of spinal dysraphism. And in this case, we consider the tetrachord syndrome, in which, as we can see, and we can see previously, we have signs and symptoms of tetrachord, for example, neurologic, urological, and orthopedic deficit. The pathophysiology of tetrachord is not completely understood, but an important rule is a mechanical traction that can reduce spinal cord blood flow, and metabolism and inoxidative damage. Other cause of symptoms are primary dysplasia, mass effect, for example, in case of lymphoma, or bone abnormality. And in this slide, we can see what type of indication we have to diagnose the spinal tether cord. A conus medullaris below L2, L3 interspace, the presence of syrinx, filum thickening, and fatty film. And I will now hand the floor over to my colleague, who will expose the new classification of spinal dysraphism and neurosurgeon.
Good afternoon, dear colleagues. After Giacomo Esposito presentation, I will continue with classification of Spina Bifida and other dysraphism and their management in neurosurgery. This new classification is a result of a 3-year project. OMNI-NET, a research portal for rare disease, asked the European Rare Disease Network to update the spinal dysraphism classification. About 100 of professionals and patients from 8 European countries were involved in the project and participated to different workshops in cities of Europe. The goal was to provide an actionable coding resource to offer an updated and updatable reorganization of this dysraphism. Our hypothesis was that all human dysraphism named as disorder could be described by a combination of 3 categories of findings, meaning phenotypes. These 3 categories are skin findings, bone findings, and spinal cord findings. Combinations of these findings lead to a category of disorders that have in common their prognosis and management. Observing heterogeneity in some categories could make us think about another significant combination and lead to a new classifications in the following years. After the on-time release of OMNI-NET in July, definitions on organization of disorders have been adjusted for a new classification you can find in OMNI-NET websites, offering an enrichment for rare disease network, but also phenotypes. The purpose today is not to list of the items that have been created or inactivated or modified, but is to explain their logical organization to guide practitioners in their neurosurgical decision and counseling. There is 5 major factors that can lead to neurological symptoms on dysraphism cases. First and worst is the open finding versus closed findings. First, if it is open, surgical closure is needed. That is the first meaning. Second meaning is the effects of the CSF leak that can lead to a possible brain impairment and even hydrocephalus. On the left part of the screen, there is a closed dysraphism with a normal posterior fossa. On the right side, you have a fully opened, it's a myeloschisis, with an authentic KRE2. And in between, it's an open dysraphism. You can see there is no skin on the sac. And but there is a mild CSF leak and just a dry posterior fossa, so not normal, but not a KRE2. Second factor is dysplasia, representing the malformative degree represented by the variation of the anatomy from the normal one represented on the left with a normal conus shape. Dysplasia can involve only a part of the posterior tract of the spinal cord in LDM here, or on the wall conus, or even the wall termination of the spinal cord in cases such as myeloschisis. In between, you have different amounts of dysplasia in different kinds of conus lipoma. The third factor is the mechanical stress received by the spinal cord itself. It can be a simple motion limitation risk, as with phylum lipoma on the left, or a wide traction with LDM, a mild traction with LDM, and increased traction with a big subcutaneous spinal cord lipoma here in the middle, or worse with saccular malformations such as myeloma negocial or mild DM on the right side, with this huge traction inside an almost watertight large sac with the extremity of the spinal cord tethered at its dome. The fourth factor is the environment. Histological environment with lipoma, amniotic fluid environment and unidirectional flow with open dysraphism, and infection or risk of it in cases such as dermal sinus with dermoid cysts that have to be operated preferentially. You can see on the right part of the slide. Time can be considered as the fifth factor. Indeed, symptoms can worsen with age, representing here by the Sphinx enigma that Oedipus managed to solve in the mythology. Adverse events or surgical treatments and life injuries can also be a factor of worsening on a fragile spinal cord, such as in dysraphism. So patient is not the same all along the life. This fifth factor led to major hierarchized head findings corresponding to main categories of dysraphism. You have first and worst the open dysraphism separated for the global neurological prognosis versus spinal cord exclusive prognosis for closed one. Split cord dysraphism represents a composite form of dysraphism because of the embryological cascade that lead to them. Spinal cord lipoma for the cocktail of dysplasia, tethering, and tumoral effect that need a tailor-made treatment proposal. Dysraphism with stalk, limited dorsal myeloschisis, mainly for the highly surgical cases, and after the not so rare and good prognosis phylum lipoma. And finally, interrupted spinal cord lipoma cases such as caudal regression and junctional neural tube defects. These cases usually don't require neurosurgical treatment and have a poor prognosis. Taking the example of open dysraphism, myeloma negocial and myeloschisis definition have been sharpened, and mild DM case have been created as an intermediate form between myeloma negocial and LDM. This organization was mainly motivated by prenatal counseling and fetal surgery treatment indication. All of them need an early and sometimes prenatal treatment. Treatment consists in a detethering and closure at the same time. Here, you can see a picture from a neonatal surgery of myeloma negocial with a dissection of the placodes, preserving the nerve roots, as you can see on the search image, before the multi-layer closure. First, tubulization of the spinal cord with PL sutures, then dural watertight closure, then aproneurotic, then skin closure. Considering split cords and lipomas, classical entities have been kept, but enlightenment of dysplasia is indicated by the separated entity of chaotic lipoma. We will see further. We know, as a community of pediatric neurosurgeon and rehabilitation doctors, have to rethink this classification. In these cases, the goal of the surgery is to optimize the abnormal environment of a dysplasia spinal cord. Example here of a chaotic conus lipoma with a large amount of dysplasia. The lipoma is going frontally to the dorsal root entry zone, mixing with the neural tissue. Natural history and surgical treatment are both at high neurosurgical risk. The decision of treatment is very rarely an emergency and has to be balanced on clinical and radical situation. After subcutaneous dissection, you can identify the entrance of the lipoma inside the dura. And you can then open it above the malformation in order to identify the normal spinal cord above the malformation. You will then dissect progressively to identify microscopically and on neuromonitoring the abnormal anatomy. Here you can see the roots that have different directions. Once identified the limits, you will resect as much lipoma as possible without taking non-reasonable risk of spinal cord injury. One down, so removal, you start a multi-layer closure, and it has to be performed with an expansion of the dural sac around the termination of the spinal cord. Example here of a split cord malformation type 1 with a bony spur between the two separated dural sac. Goal here is to remove the spur to identify the two dural sac and to reunify them in one and to detether at the same time the abnormal tethering you can find, such as a lipoma here or a phylum lipoma here on the right. Dysraphisms with stalk are mainly represented by limited dorsal myeloschisis, described by Dackling Pung. The stalk is typically neuroglial and between the posterior part of the spinal cord and a cutaneous stigmata. Preventive surgery is recommended and consists in a single stalk removal from skin to the intradural space. In conclusion, I would like to send you 3 ideas and support. First, surgery of a spinal dysraphism is an environment optimization of an irreversibly dysplasic spinal cord. You cannot go back to normal. The goal of the surgery is always the long-term functional outcome and not just an radiological detethering. The surgery is an included part of management inside the whole journey of the patient from diagnosis to senescence to old ages. Thank you very much for your attention.
Well, thank you very much for this presentation, very clear from my point of view. And again, please consider for the question that we have, you can type your question on the below side, and please, we can see the slide of the question. But anyway, you can write on the below part and send to us, and we will collect all the questions then, and we will answer to the next webinar. Please, Dr. Zimar.
Дякую нашим колегам іще раз, докторам Еспозіто та Сен-Дені, за те, що вони освіжили і доповнили наші сучасні знання. Знову ж таки, хочу підкреслити стосовно питань, їх можна написати у чаті, їх можна надіслати в коментарях, переглядаючи ці вебінари у Ютубі, і можна так само написати безпосередньо на пошту. Будь ласка, покажіть адресу.
We have received before and during the webinar some questions that I would like to introduce in order that you can know that we will answer to this topic. And one question is about the Duramather plastic, how often are used in during the neurosurgical repair. Other question is about the simultaneous surgery management of Spina Bifida and Hydrocephalus, and I suppose that is when there is indication and how to perform. Other question is regarding the primary and secondary tethering and when there are the indication, and also one very good question about the intraoperative control, and we know that the neurophysiological control is not used in all hospitals, and this is not, I believe, a concern only for Ukraine, but of all Europe, and actually maybe is quite common, but until 5-10 years ago is not so common to have in all center. And other question is about the shunting type that could be preferred, and again, when and which is the best one. And so please, Dr. Zimak.
Дякую колегам за вашу активність. Будь ласка, задавайте питання англійською чи українською, записуйте їх, подавайте їх в будь-яких доступних формах. Хочу так само повідомити, що всі учасники вживу сьогоднішнього вебінару отримають сертифікат учасника, а ті, хто дадуть відповідь на опитування, яке орієнтовно десь через годину ви зможете отримати, вони так само отримають іще додатково по 1 балу СМЕ – Continuing Medical Education.
And I see that there is another good question about the fetal surgery for myelomeningocele. And you have seen the presentation by Dr. Timothée de Saint Denis about the nucleasification. And in my mind, this is very useful because we have to be able to decide, to define a diagnosis. This is very important, especially for the fetal diagnosis, because the diagnosis between myelomeningocele and the myeloschisis and the could be in some cases not so completely different, and the indication when to operate in fetal surgery could be, of course, related to a more accurate diagnosis. And again, for the which kind of spinal dysraphism to operate is very important. And you have seen the presentation about the opportunity to classify this dysraphism according to the skin lesion, spine lesion, and the radiological signs. And we know from the urological point of view, I am a urologist, and of course, for this aspect is very important for me, that we have high risk dysraphisms and other with low risk dysraphism, and it could be important to have a more accurate diagnosis, and also in order to best use of our resources to understand which kind of dysraphism require a long-term and a more invasive diagnosis from the beginning, and respect to other ones that require a safer follow-up. Please, Dr. Zimak, if you have some comments.
Так, я також хочу подякувати, хоч я і не є нейрохірургом чи дитячим урологом, але як лікар-генетик я також бачу досить багато корисних практичних речей з точки зору впровадження нової класифікації.
Yes, I've seen another question about the neurological outcome about the fetal repair. And we know from the serious and mainly the North American experience that they perform a multi-center study, but we have also very good experience from center in Europe. First of all, the center in Paris of Professor Jean-Marie Joannick, and also center in Leuven in Belgium, also center in Spain, in Barcelona, that they have seen that we have a great advantage about the mobility and about the reduce of the shunting required, but the results for the urological point of view are very discordant. And we have to say about that until now, we have a different approach to manage, to evaluate these children after the birth. And this could be an explanation about we have no clear results about the urological point of view. For example, we use for these children the same approach that we use for the postnatal repair. That means that we have to perform urodynamic. But when to perform urodynamic, which is the correct time to perform urodynamic after fetal repair? Normally, we try to avoid to perform urodynamic after the first day of life, and we consider a phase of spinal shock for 3 months, and we evaluate these children after 3 months. But when we have fetal repair, we have to consider that some weeks are spent before the birth. So theoretically, we can evaluate these children after the birth immediately. And it is very interesting in this, the experience of the Barcelona group that reported that in these children that they evaluate after fetal repair, they observed either bladder pressure respect to the bladder pressure or activity of the bladder pressure that they observed after the birth repair. So this is a point that we will discuss, of course, in the next webinar about the urodynamics and also the urological management. Dr. Zima?
Так, хочу сказати, що в Україні також є перша група, яка розпочала займатися фетальною хірургією спінальних дисрафізмів. І також з радістю хочу запросити наших колег до наступного перегляду, до наступного вебінару, який відбудеться 1 лютого. І саме він буде присвячений основним питанням нейрогенного сечового міхура. Етіології, класифікації, фізіології, ну і діагностиці, а вже ж. Пане Мусієло?
Yes, I've seen a question about the chance of to obtain results about with the fetal repair for the urological prognosis. It is debate because from some colleagues that they have a large experience with the fetal repair, they suppose that maybe there is a damage on the posterior roots that happens before the repair, and these posterior roots are the responsible of the control of the bladder. So in this, for this, the fetal repair is not so useful for the urological. On the other hand, as I told you before, maybe we have to change something about the management of these babies treated in fetal repair. And maybe, for example, if the data of the Barcelona group will be confirmed, could be useful to have a more aggressive approach with this in these children, not only starting the clean intermittent catheterization, but maybe using a higher dosage of anticholinergic, because we have to treat higher pressure. And other option could be always, if this data will be confirmed, to have a continuous derivation instead a clean intermittent catheterization, maybe using a suprapubic drainage of the bladder. And for some aspects, the management of a neurogenic bladder is very close to posterior ureteral valves bladder, when we have, in this case, for posterior ureteral valves, an anatomic obstruction, while in the neurogenic bladder, we have a functional obstruction. But I'm talking to the pediatric urologists, they know that in some cases, we prefer to have a suprapubic drainage and then to perform the posterior ureteral valve treatment and removal, because we need to preserve the bladder and the kidney function. And maybe in some cases could be useful to consider this approach. Do you have some comments?
Так, це досить цікаві питання і досить цікаві проблеми, які у нас постають. Сподіваємося, що наші колеги також активно включаться до обговорення і до коментарів.
I believe that for this could be very important also to have the opinion of Dr. Simak as an anesthesiologist, because of course, as a surgeon, we know that we can operate if we have anesthesiologist, and this could be also to consider regarding, for example, the question and to management of the spina bifida closure and hydrocephalus, and also when to perform a surgery for primary and secondary detectoring, because in some cases we know that we have to perform to treat other disease. One example for the spina bifida is very common in patients with anorectal malformation. If we have a anorectal malformation, we have to perform colostomy, we have to perform the repair of the anorectal malformation with I believe that is common to operate with the Penny approach, and then to perform the colostomy closure. And so we have to consider that in case that there is anorectal malformation associated to spina bifida, we have to perform a different anesthesia, different operation, and so the repair of the tethering must be considered for timing. Again, we have in some cases an association with posterior ureteral valves. We have an association with the double urethra, and because I have observed in many different cases, and of course we can consider that we have other malformation as a cardiac malformation, and that can increase the risk of anesthesiology. And do you have any comment about that?
Так, це типова мультидисциплінарна проблема і, скажімо, і ортопедичні моменти, які також виникають в процесі надання допомоги таким пацієнтам.
And for the summarizing, I believe that we have all the questions to answer for the next webinar. Please, I invite all the participants, if they have other questions, to send to us in order to have time to prepare an answer with the participants for the next webinar. The next webinar will be the 1st of February. The topic will be neurogenic bladder classification, pathophysiology, and diagnosis. And one of the speakers will be myself with Professor Nyman. And before our presentation, we will answer to your question. Dr. Zimak, please.
Шановні колеги, відповіді на наші сьогоднішні питання ми зможемо вичерпно отримати надіслані, як уже говорилося, на пошту, і на початку наступного нашого вебінару, який планується, повторю, 1 лютого. Професор Джованні Мосієло якраз представить нам основні фундаментальні підходи до поняття нейрогенного сечового міхура. Професор Мосієло.
Yeah, I would like to thank to all, and yes, for every participant who attends the live webinar will receive a certificate of attendance, and 1 hour after the schedule, the finish of the webinar, you will receive also a survey to complete. I invite you to do that because it's very important for us to receive your suggestions, your comments in order to improve the next webinar. And I hope that you can consider some difficulties and that some concerns that we had today, because it's not easy also on preparing the presentation to consider that we need space for the translation and for the subtitles, and we would like to improve on the next presentation, also regarding the topic and also regarding the timing. And those who complete the survey will also receive a certificate confirming the hour of 1 CME credit, and it will be happens around 3 weeks after the webinar. And regarding the question, and you still have the opportunity to ask questions to the presenter. Of course, you can answer using the survey that you will receive later. And watching the recording on YouTube, please use the comment section. Otherwise, please send an email to Darren Sheehan that is supporting us. More general feedback or problems can also provide using the survey or using the email address above. Please not to be shy and send us to our comments because we require this. And for further information, you can use the email address on and check on the website OMNI-NET Ukraine, International Federation of Spina Bifida, ERN EUROGEN, ERN ITHACA, and ERN Care for UA. And please use and send your comments. Please to leave the podium to Dr. Zimak. I would like to thank all for your participation. Dr. Zimak.
Шановні колеги, деталі подальшого спілкування, сертифікації ми зрозуміли. Я хочу подякувати всім організаторам сьогоднішнього вебінару за цю участь. І, а вже ж, ми тут, українці, дякуємо нашим Збройним силам, які дали нам можливість сьогодні спокійно попрацювати над своїм професійним вдосконаленням. Ще раз дякую всім учасникам. Запрошую до продовження, до участі у наступних вебінарах. І, безумовно, що ваші відгуки дуже важливі для того, щоб вдосконалити такі вебінари.
Thank you very much. Thanks to all. A special thanks to Darren Sheehan that support us for this presentation and for the technical part. And a special thanks to OMNI-NET and for this organization that, as I told you before, is something that is very, very useful for all and could be used, I hope, in the next future also for other countries, because it is a fantastic opportunity, thanks to the International Federation of Spina Bifida, that we have in order to have a contact between specialists from different countries. And I hope that this will be only the beginning of our relationship, because it will be very useful to receive ideas, to share ideas, to receive support each other. And I believe that we come back in the next future after the end of this first series of webinar with the other webinar and on these topics of neurosurgery. Thank you very much. Please, Dr. Zimak.
Я також, в свою чергу, хочу подякувати всім нашим учасникам і сподіваюся, що українці зараз стоять на захисті свободи і гідності, і розумінь демократії. І, відповідно, українці, сподіваємося, і українські лікарі будуть ставати учасниками європейської медичної сім'ї. Дякую всім. Дякую тим, хто долучився до підготовки цього вебінару. Дякую учасникам.
Dr. Ruzen, if you are here, if you are present, please, we left you the podium for the last words.
Well,
Thank
I want
you
to
very much for your support and this fantastic idea.
Well, thank you all so much. And it was really a very good starting webinar for the topic-specific webinars for multidisciplinary care for our community. And it's very much needed. And I welcome the following meetings. And thank you so much, Dr. Zimak, Professor Masiello, and the two speakers here. And I hope that the following actions will be of inspiration. So I'm looking forward to it. Thank you.
Thank you to all. Bye. Thank you very much for all. Thank you. Bye-bye.